Thank you, everybody. I cannot see you, but I see that some people in the Teams meeting have arrived. I will talk in the next 30 minutes about vascular complications after pediatric liver transplantation, and then it's all about the portal vein. My name is Hubert van der Doef. I'm a consultant in pediatric hepatology in the University Medical Center Groningen, in Groningen in the Netherlands. And first, I would like to share some details of my country, the Netherlands. We are a small country within Europe. We have 17 million inhabitants and 3.4 million children. We have a thing with riding bikes. We really like our bikes, and we have more bikes than inhabitants. And from young age, what you see here is that a lot of children already ride bikes. So that's something of the Netherlands. We are located in Groningen. It's in the north of the Netherlands. We are an old city. You see a picture of the city below in the slides. And we are the second oldest university in the Netherlands. We are founded in 1600. If you look on the map, you see the red dot, and that's our center. So that's where we are located. We are a national liver center, also a lot of pediatric surgery. We have a rich history of liver transplantation. In 1997, we did the first adult liver transplantation. In 1982, we did the first pediatric liver transplantation. And we are a national referral center with 20 to 30 pediatric liver transplantations per year. And we also do a lot of pediatric liver surgery like resections, shunt closures of portosystemic shunts, and also other shunts like the Mesorex bypass. And we also have a collaboration with the International of Interventional Radiology. I'm really interested in portal vein complications after liver transplantation, and this led to a collaboration within my center and also an international collaboration in which we investigate portal vein obstruction problems. And it's called the Portal Registry. I'm leading it together with Reinhard Bokkers, an interventional radiologist in Groningen. And we have a PhD on this topic, Bada Alvarez. And we are the first international registry of portal vein obstruction. That's the anastomosis, stenosis, and the thrombosis after pediatric liver transplantation. And we have 3 topics, like we investigate the cure and management, prevalence, and efficacy of treatment. And till now, 31 interested centers are. It's a global registry, and 18 centers are almost ready to include data. And so this is it's a map of all the centers who are participating or have interest. In this topic, I will give you an overview of the portal vein obstruction. We'll start with prevalence numbers, then risk factors, diagnosis, efficacy of treatment, and then what we do in Groningen management, and then recommendations for future research, because a lot of this on this topic is unknown. I would like to first start with the take-home messages, and we'll come back to it also at the end of this the PowerPoint slide presentation. So the portal vein obstruction, the clinical presentation based on physiology is portal hypertension, but also decreased portal perfusion. And a lot of the public reported patients are on significant portal hypertension. So it's 26 of the patients have a GI bleeding and 50% has ascites. So it's a huge proportion of patients who has serious symptoms. And we have risk groups. Basically, it's associated with portal hyperplasia. So the young patients for liver transplantations with biliary atresia, they have the highest risk. and also a living-related liver donation. There's also a high risk of a lot of reports on it. The second take-home message is if you have a portal vein anastomosis stenosis, then the primary patency of a PTA is good, with 3 years patency of 70 to 80%, and of a stent placement is excellent, it's 95% at 3 years. We recommend the PTA as a first choice of treatment. And for the portal vein anastomosis thrombosis, the primary patency of a Mesorex bypass, I will go on that later, is also very good with a patency of 70 to 80% at 3 years. And that's also the first choice in patients with a thrombosis. Also, a lot of recommendations for future research. A lot of it is unknown, so like the screening protocol with Doppler ultrasound, who and when should you screen after transplantation, the diagnostic criteria for an anastomosis stenosis, or indication for invasive diagnostics, the efficacy of portal vein reconstructions in high-risk groups, so what to do with the difficult portal vein anastomosis, the portal hyperplasia, the timing of a stent placement, endovascular recanalization in anastomosis thrombosis, and the anticoagulant therapy after vascular interventions. 2021 was a good year for the portal vein obstruction. We had 2 reviews. Basically, they were published at the same time period. So we published a review, and Singapore also published a review. We did so there were some differences within the reviews, but they are the basis of the talk. So our review has included all treatments, and the Singapore paper concentrated basically on endovascular treatments. The prevalence, yeah, that's really difficult because you have a lot of range. So I say now 8 to 12, but you can also see papers so from 0 to 30. And that's because they are single center studies. The distribution of risk factors differs within studies. The prevalence in high risk groups is unknown. So like the patients with portal hyperplasia, the screening protocol is unknown, and the diagnosis of a portal vein anastomosis stenosis is unclear. So the cutoff values using the Dopplers. The risk of a PVO is related basically to portal vein hypoplasia. So in the recent review we did, we investigated 22 studies, 362 patients, and in most studies the patients had an age below the age at transplantation below the 2 years of age, 77%. Most patients were biliary atresia, and also most patients were after living donor liver transplantation. I don't know why the living donor liver transplantation is a risk factor, but the other 2 are related to the portal vein hypoplasia. I will go further on the vascular reconstructions of the portal vein during transplantation, but first I would like to show you a normal pediatric liver transplantation, a left lateral segment, like we see a lot. And yeah, you see now a very big portal vein, but normally if you do a patient with biliary atresia, then the recipient has a very small portal vein. And for this reason, there's a lot of publications about what type of portal vein anastomosis you perform. So you see normally you do an end-to-end anastomosis if the diameter is enough. Then you also could do an interposition vein graft. That's a vein graft which you don't have enough length, and then you interposition another venous graft. but you have then 2 anastomosis and also a higher risk, but I will go on that later. And you also have the portoplasty. Portoplasty is a preventive measure, and also the Brussels paper in 2011. They say how they do it, and it's a longitudinal venotomy, and then they place a vein graft in that, and then you have you expand the diameter of the vessel, and therefore it prevents against the portal vein problems. This is also from Brussels, where they have investigated all types of liver transplantation, so not only the pediatricia, but was the whole living. And the risk I see is PVO-free survival. So the lower the risk, the higher the portal vein obstruction problems they have. And you see the lines. So they have compared the end-to-end anastomosis, the portoplasty, and the interposition vein graft technique. And here you see that the interposition vein graft technique has a significant lower PVO-free survival. So they have a significant higher risk of developing PVO in time. And some year later, the same group from Brussels also had expanded the patients, and they had made a subgroup analysis on pediatricia patients who had of which a lot of patients had portal vein hypoplasia, and there you see in the blue box that if you do an end-to-end anastomosis, you had a risk of 10%. If you do a venous jump graft, it's an interposition graft, you had a risk of 27%. And if you do a preventive portoplasty, you reduce the risk to 5%. Portoplasty reduces the risk of a PVO. However, and that's still on debate, the numbers are very low, and it's only a single center study. There are also other reports of portoplasty or other portal vein reconstructions, but there's a lot of debate on it, and there are no guidelines at the moment. If you look at the patients we have treated for a portal vein anastomosis or thrombosis, we see that in our recent review that they have a high frequency of portal hypertension, and they mainly focus on portal hypertension. You don't see any reports which report on a decreased portal perfusion. A graft function also is not reported well. But in those patients, a significant amount of patients have severe portal hypertension with gastrointestinal bleedings, 26%, and ascites 15%. And also a lot of patients have a thrombocytopenia, so that's thrombocytes below the 150. But also you could also flip it around, and that's 22% of all patients have normal thrombocytes. So you can that's also known in young children, that you can have significant portal hypertension with normal thrombocytes. And the diagnosis, in all guidelines, all papers, Doppler ultrasound is the first choice of screening and diagnosis, portal vein, thrombosis, and stenosis. What exactly the cutoff values are, that's still a debate. We use a velocity of the anastomosis of more than 125 centimeters per second, or the ratio, which is bigger than 3 to 1 between the velocity at the anastomotic versus the pre-anastomotic. And then if the Doppler ultrasound is a signs for portal vein anastomosis stenosis, then we do a CT scan and then we go further for invasive pressure measurements. There are some questions which that there's no uniform screening protocol after liver transplantation. So which group and how many and how many per year and how small. So the natural course of the natural history of a portal vein anastomosis stenosis is unknown till now. So there's a need for a uniform screening protocol. Also, what I just discussed, that the diagnostic criteria for Doppler ultrasound, but also for invasive pressure measurements, what kind of pressure gradient over the anastomosis do you use as a cutoff for treatment? And maybe spleen stiffness in the future will also can also be used as a diagnosis or for the follow-up. Then we'll go further to the treatment. So the first thing you can do is PTA, so a percutaneous transluminal angioplasty, with or without a stent. You have different. You can do that transhepatic or transsplenic or transmesenteric. Here you see so in the A you see the stenosis, and on the B you see the dilatation and the PTA. So and then on the C you see the result of the PTA. I will go on that later on. And another technique which frequently is used for thrombosis is a Mesorex bypass. And this is so it's a shunt. So it's the most popular surgical shunt for thrombosis. And that's because it allows, so you have a connection with the liver, and you also get portal perfusion. So the liver is perfused again with portal blood after the shunt, and that's contrary with other surgical shunts. On the left side with C, you see the technique, and the Goyette published also a paper on it, where they described all the techniques. In the recent reviews, so of the Singapore and Groningen review, we see that the PTA and stent has a good result for an anastomosis stenosis. So all there were nearly 280 patients treated, and a 3 years primary patency was 70 to 80% with the PTA and 95% with a stent. And the primary patency is the patency of one procedure. So we see that if you do one procedure, then after 3 years, like 70% is still patent as a patent anastomosis with one PTA. And but however, they didn't specify if it was a second or first or second PTA, because that could be that could outweigh the long time risk of a stent placement, because the PTA you only do it during the procedure, and the stent you carry with you. And also, so the questions for this procedure are the optimal route, transhepatic, transsplenic, transmesenteric, and also the timing of a stent placement, because like I just discussed before, for a stent we recommend lifelong anticoagulant therapy. For PTA, it's only temporary. Then I will go further to the Mesorex bypass, and and it also has good results on an anastomosis thrombosis. In the recent review, we had nearly 50 patients, and they had a primary patency also for the Mesorex bypass for 70 to 80%. So that's really, really good. One paper was they published about endovascular recanalization. So and they also had a very good 3 years primary patency, but only it was one report. So we couldn't recommend it. A lot of is unknown about the anticoagulation therapy after all the procedures. All used heparin intraprocedural, but there was a huge variation in type and duration of anticoagulant therapy. So everything was used in the papers. We didn't see, so there's a new anticoagulant therapy, the DOACs. So it's a direct acting oral anticoagulant, and there's a huge profit for the patients that they don't need any follow-up with blood tests, because if you do a vitamin K antagonist, you have to always test it. But you don't have that. You don't have to do that. But there are no reports in DOAC, so it's really difficult to make a recommendation about that. So the management of portal vein anastomosis, stenosis, and thrombosis. We also both reviews came to the same conclusions about the stenosis, that you first do a PTA, then a second PTA, and if the second PTA fails, then you place a stent. And in the other review also, if you have a thrombosis, we recommend to do a Mesorex bypass, and maybe to do an endovascular recanalization if you have really good experience that within your center. But it's a maybe, and the Mesorex bypass is really, they have good numbers. The anticoagulant therapy, that's my personal opinion. There are no guidelines for that, but our guideline is that we do, after PTA, we do prophylactic low molecular weight heparin for 6 weeks. For a stent, we do a lifelong vitamin K antagonist, and for Mesorex bypass, we do that for 3 months. And we follow them up with Doppler ultrasound. So that's I want to conclude with the take-home message which you already had. So the clinical presentation of a portal vein anastomosis stenosis based on the physiology is portal hypertension, but also decreased portal perfusion. The reports are mainly on significant portal hypertension, which is significant in these patients, with 26% of GI bleeding, 15% of ascites. And the risk groups are portal hyperplasia with pediatrasia and young age at liver transplantation, and also the living-related liver donation. The second take-home message is the portal vein anastomosis stenosis, that you have a good primary patency and an excellent primary patency of a stent, but that our first choice is a PTA of treatment. And that for the portal vein anastomosis thrombosis, the Mesorex bypass has a very good patency, and that's also the recommendation. The recommendation for future research, so the screening protocol, the diagnostic criteria for an anastomosis stenosis or indication for invasive diagnostics, the efficacy of all the different portal vein reconstructions in the high risk groups with portal hyperplasia, timing of a stent placement, further discuss on endovascular recanalizations and the anticoagulant therapy. We hope that some of these questions will be answered by the portal registry, and we would like to point out that the portal registry is still open for participation. We have tight deadlines, so if you are interested, please contact us. You can contact me by email or Bara Alvarez, the PhD, or you can look at our website. So the deadlines are the 1st March. That's the deadline on curative management. It's only a questionnaire per center, and no IRB approval or clinical site agreement are required. And the 1st September, that's the closure of the database. That's the others. I would like to thank you, and the site is open for questions. I've also put the QR code for the website. So if you have a mobile phone, you can also use that for visiting our website. Thank you very much.